In the cardiology section from BNB lecture 1 is bicuspid wall is located between left atrium and left ventricle. It is also called mitral wall. It is two cusps. Other wall three having three cusps. Heart drains into coronary sinus. Right ventricle the most anterior portion. Left atria the most posterior portion. Left atria then we have in the backward esophagus, then aorta. In mitral stenosis, most commonly structure affected is esophagus, coronary arteries, which are the branches of aorta. LAD, uh, interior wall, septum, apex, left circumflex, lateral wall, PDA, that is inferior wall, and inferior septum. 90% right shunt dominant, that is PDA from right coronary artery. 10% left shunt dominant, that is PDA from left circumflex. Occlusion in the order of LAD, then we have RCA, then we have left circumflex. Uh, Anterolateral uh, pupillary muscle has dual blood supply, that is LAD plus left circumflex, which is least commonly infarcted. Then we have posteromedial pupillary muscle, uh, pupillary muscle. Okay, uh, that is a single blood supply, that is either from RCA or left circumflex. The most commonly infarcted in inferior wall MI. Inferior wall ischemia leads to inferior wall MI plus uh, acute heart failure. AC node plus AV node, they are supplied by right coronary artery branches. AV node is located in the interatrial septum, while bundle of His is located in the interventricular septum. Lecture 2. Stroke volume is equal to end diastolic volume minus end systolic volume, right? Ejection fraction is equal to stroke volume divided by end diastolic volume. Since stroke volume equals end diastolic volume minus uh, end systolic volume, so ejection fraction equals end diastolic volume minus uh, end systolic volume divided by end diastolic volume. Cardiac output is equal to stroke volume multiplied by heart rate. Systolic BP is largely determined by stroke volume, while diastolic BP is largely determined by a, a peripheral uh, vascular resistance or total peripheral resistance, that is TPR. Pulse pressure equals systolic BP minus diastolic BP. Pulse pressure is directly proportional to stroke volume. Mean arterial pressure equals diastolic blood pressure plus one third of pulse pressure. Our BP spends more its time is diastolic blood pressure, so that's why more diastolic blood pressure. Now we have cardiac output determinants, which are for preload, afterload, contractility, and heart rate. Preload increases, uh, that will lead to increased cardiac output. Amount of blood loaded into the left ventricle or stretch or length on or in fibers prior to contraction. To increase preload, what we can do, aid volume, that is blood transfusion or IV fluid. Second is we can decrease heart rate. Third, constrict veins. To increase preload, we will do the opposite, like remove volume, like bleeding, dehydration. So number second, increase heart rate. Number third, pull blood in veins. So preload is also written by the left ventricular end diastolic volume or left ventricular end diastolic pressure. Afterload equals, okay, these are the forces resisting flow uh, out of the left ventricle. Forces resisting flow out of the left ventricle increase when BP is high, aortic wall is stiff, hypertrophic, obstructive, hypertrophic obstructive cardiomyopathy, and subaortic membrane. To increase afterload, raise mean BP. Number second, obstruct outflow. Ejection fraction is the index of contractility.